Welcome everyone, my name is Réka Petra Tóth, and I would like to present you my PhD topic, which is Insights to Mechanical Ventilation. So I am a PhD student here at Semmelweis University, and I envision a future where everyone has access to advanced medical technology, no matter who they are. And my mission is to improve the effectiveness of current technology. In order to do so, we've launched 2 projects in this year. First was systematic research and meta-analysis, and the second one was a retrospective observational study. So let's talk about the first project, which is comparing the effectiveness and safety of adaptive versus conventional modes in invasively ventilated patients. So we do know that half of our patients in the ICU are requiring mechanical ventilations, which is far from having no risks, such as ventilator-associated lung injuries or pneumonia. And we could say that the longer the patients spend on mechanical ventilator, the more likely they are developing these complications. Nowadays, we are using manually adjustable ventilators, which are not able to adapt to the patient's needs in real time, thus creating elongated duration of ventilation or more complications. However, there are available new systems called closed-loop systems, which are able to adapt to the patient's needs in real time by analyzing the patient within breath or breath to breath. However, so even though these systems sounds better than the conventional methods, we are still lacking of evidence how effective they are and how safe they are. So I would like to investigate it further and find out the true impact of these adaptive modes. Our clinical question is, are adaptive modes more effective and safer than conventional modes? To do so, we are going to use the PICO framework, P for invasively ventilated patients, comparing conventional modes to adaptive modes, and our primary outcome would be the duration of ventilation. And we hypothesized that adaptive modes significantly reduce the duration of invasive ventilation. We conducted our systematic search in 3 databases, PubMed, Embase, and Cochrane. We used 2 domains, adaptive modes and conventional modes. We ended up around 30,000 articles, and after the duplicate removal, title and abstract selection, full text selection, we ended up around 50 eligible articles for data extraction. So here you can see our progress whatsoever. We're done with the data extraction, and we are about to start the risk of bias assessment. So let's start what we found from what we get out of the data extraction. We analyzed these unlisted outcomes, odds ratio for dichotomous outcomes, and mean differences in continuous outcomes. I will present 3 outcomes. The first one is total duration of mechanical ventilation, which I said previously, it's really important for us as critical care professionals to reuse it as much as we can. As you can see, here are the studies that we used. We had 1,400 articles that were put together, not articles, population that we put together, and our mean differences was around -1, which means that by using adaptive modes, we could reduce the days of mechanical ventilation per 1 day, which is clinically relevant, but as we can see, the heterogeneity is quite high. There occur some questions about the results. So our second outcome was the duration of invasive mechanical ventilation days, which is differs from the first one by not taking into account the non-invasive ventilation part. So here you can see that we have around 1,000 patient population, and our finding was that the mean difference was -0.67, which is kind of around 2/3 of a day. However, this is a small number, which means that clinically it's not that relevant, and our confidence interval was suggesting us that it's not statistically significant. Our third outcome was ventilator-free days, which defined by the overall days that were spent without mechanical ventilator during the stay of the hospital. As you can see, that our mean difference was around 1.5, but it was due to the wide confidence interval, it's statistically not significant. So what we could say that our strength with these findings is that our articles was mainly randomized controlled trials, and there were some clinical relevant outcomes, but the limitation is that there were some high heterogeneity there, and also most of them were statistically not significant. So let's talk about my second project, which is a retrospective observational study, model-based optimization of medical ventilation. So as I mentioned, we are ventilating a huge amount of patients with a really high risks, high complication rates. We do know that by optimizing the parameters, we can improve the outcomes. Our ventilators are already using model-based optimization by using simplified models such as RC models. Also, we could fine-tune these models, these results, by using special maneuvers. But these maneuvers do not have standardized evaluation, which means that it's up to the professional's competency. Why is it a problem to use oversimplification? So as you can see, if there is the blue line, which is the measured value, and you can see the green line, which is the RC model, which says that pressure and volume related to each other in a linear mode. What we would like to achieve is a mathematical model that perfectly fits the measured value. Because if you use the RC model and you derive parameters out of it, you end up with a constant. But if you use a function, you will end up a more better estimate to reality. Thus, you can base your decision on it. You can have a more lung protective approach to the patient. So we would like to validate a model and check which given patient population suits the best. So our aim is to test the accuracy of the mathematical model and the right parameters to optimize the ventilation. So our research question is, how accurately can our mathematical model estimate the pressure-volume flow relation in mechanically ventilated patients? In order to do so, we would like to use the PIRD framework, P for mechanically ventilated patients, E for mathematical model, and R for pressure-volume flow measurements. And we would like to see how much agreement do they have. We hypothesize that mathematical models can accurately estimate the pressure-volume flow relation in mechanically ventilated patients. So I would like to sum up what was already said. Two projects has been launched, and we would like to submit these, the first one in this year, October, and the second one next year. So I would like to finish my presentation with a quote. Those doors won't open while you stand and watch them. And thank you for your kind attention.
Could you please tell more about the adaptive model for ventilation? How does it differ from the conventional one?
Yes, so the difference between the two that when we use conventional modes, in order to make changes on the ventilator, the clinician has to get back to the ventilator, check the measurements, and then set the ventilator accordingly. Volumes, pressure, whatever modes does they use. But with the adaptive modes, it has some settings, some equation behind the whole system, and you can limit which range it should be stay, and it will keep the patients in that stay and in that place. Also, some adaptive modes, for example, Smart Care or some other ones, are pretty good at weaning, so it can help you decide when the patient should be extubated or sent to weaning procedures.
Why do you think that high heterogeneity in a statistically significant result represents a limitation of your study?
Yeah, most of the time high heterogeneity is not a limitation, but I think, for example, at the first outcome, the heterogeneity does impact our results. So because of that, I do believe it's a limitation, but it can be our strength as well, because it's more to investigate, for example, finding out subgroups or finding out what are the confounding factors for that heterogeneity.
So in your opinion, if the heterogeneity, between study heterogeneity was lower, where would the result move to? Would it more favor adaptive modes, or would it more favor conventional modes if the between study heterogeneity was lower?
That's an interesting question. I think, based on what I've already gathered whatsoever, it depends on what patient population we are looking at. So it's just a guess. But if we are looking at, for example, patients with pulmonary comorbidities, I believe it will favor the adaptive modes. But with patients who have no pulmonary comorbidities, might likely to have no effect or less effective.
Do you know any meta-analysis restricted for a particular patient group, such as post-operative patients or post-operative cardiothoracic patients?
We might want to do a subgroup analysis, since when I gathered all the material that is out there, we ended up to patient population. That was, one is the cardiac surgical patients, and one was the general ICU patients. So in the long run, maybe we would like to do that as well, but not in a separate meta-analysis, at least not at this moment.
And in the literature?
In the literature, well, for adaptive modes, there were, so where they included all the adaptive modes, there were none. But for example, for the weaning part, like which one is the better for weaning or after post-operative care, there are some, so very good one.